Next speaker will be Professor Nelson Andersson from Sweden. His talk will be University Hospital Uppsala experience with irreversible electroporation.
Right, good afternoon, ladies and gentlemen. First of all, I'd like to thank the organisers of the meeting for inviting me here and letting me share our experience so far with irreversible electroporation, or nanoknife, which is the trade name. Okay, I'll just briefly go through what IRE really is. And it's based on the fact that if you place a cell in an electrical field, we give short electrical pulses, you'll create little pores in the cell membranes. And the oncologists will know about this because it's used in oncology as well to increase cell membrane permeability. But if you set the electricity correctly, these little pores will remain after you stop giving the current, which means the cell will die, because a cell with holes in the cell membrane is an old cell. So we're mimicking apoptosis. If you can give more energy by either increasing the pulse length or giving more volts in each pulse. But if you increase both, you end up in the upper limits up here, where you're actually giving a thermoablation. It's not as bad as it sounds because the machine has a built-in stop. We can give up to 3,000 volts and 50 amperes, which is fairly frightening current when you're in the liver a few millimeters from the heart, but it does work. But if you try to go above, or if the conductivity of the tissue will set you at a level where you will have more than 50 amperes, the machine will just shut off and tell you this is too much. You need, obviously, at the moment, you need at least 2 needles to have 2 electrodes to send the current in between. If you look at how this irreversible zone in the middle here looks, you realize that if you want a safety margin in 3 dimensions, you really need a minimum of 3 needles. And it turns out that most of the time we work with between 4 and 6 needles to get a large ablation zone. The largest ablation zone you can get with placing up to 6 needles in a given pattern is like a sardine tin. So you've got a cylinder with a depth of about 3 centimeters maximum and a diameter of 5 centimeters. So if you want the cylinder to be higher, you just have to pull the needles back and keep giving more pulses. This is what a specimen looks like after treatment. As you can see, we've created basically apoptosis. We've killed the cells, and you still have the tissue structure intact. And that's the vital part, because anything that has a tissue structure like vessel walls will have a collagen wall. And even if we destroy all the cells in the wall, we'll still have the actual tissue skeleton intact. And new cells will move in. It's been shown in animal experiments that the intima of any vessel will be completely gone after an IRE treatment, but it will repopulate in 2 to 3 days. Initially, we were a bit worried about treating across large vessels, saying we might create an embolus because we have no proper vessel wall. But that's not turned out to be the case, fortunately. You saw this slide earlier on as well today. The advantages are that if this is, you've got the ablation zone here, and if this is a hepatic vein, and as it is, and you have a tumor cell that grows on the vessel wall, definitely with RFA and probably with microwaves, you have a problem with the heat sink effect. A cell that is actually growing in the vessel wall will never be more than 37, 40, 45 degrees, not enough to kill it, and you'll have a local recurrence. If that had not been a hepatic vein but a portal vein, you would have had a bile duct accompanying that as well. And if we tried to do it with a thermoablation, be it microwaves or RFA, you would have destroyed the bile duct. Another serious advantage, in my point of view, is that as we keep the vessels intact and the tissue skeleton or tissue pattern intact, the ablation will disappear much faster. I mean, if we do a microwave or an RFA ablation, we'll have ablated areas that we can see for years afterwards. And if you're ablating many metastases or several HCCs, or recurrent HCCs in a patient, after a while it soon becomes slightly difficult to know what is a treatment area and what is actually something new, because the liver will look like a Swiss cheese. Whereas with this method, it disappears within a few months. The machine will give you a 300-volt pulse to begin with before you're allowed to start. And that's basically to make sure that the patient is under enough muscle relaxation. You can imagine that if you put 3,000 volts through a patient that's not muscle relaxed, you get some interesting effects. I was told that one of the first patients where they didn't think about it and put electrodes around the pancreas and gave a few pulses, the patient, though under general anesthesia, sat up on the table with a tube hanging through his mouth. And then we want to give 90 pulses as a treatment. You can divide them into 10 plus 80, or you can give them in sequences of 20 pulses and then another 20 pulses, but you must always reach 90 to 100 pulses, because that's when we have the treatment level that will remain. An advantage of giving the pulses in cycles is that we know now that we do actually give a little bit of heat just by the needle, and that is less so if you give it in pulses, because the tissue has time to cool down, because you're treating between each two needle pairs at a time. It's not like you're treating between, if you place 6 needles, you will have 10 needle pairs if you pair them up correctly. And it's not like we're just sort of wham treating between them all at one go. We're treating between each needle pair at a time. So if you do 20 between 2 needles and then move to another pair of needles and give another 20 pulses, the heat will dissipate with the first ones. Your anesthesiologist will need to be aware of serious muscle relaxation. We won't do it unless they have a PTC monitor. TOF monitor is not enough. TOF 0 and the patient will still twitch too much. So it basically has to be done with rocuronium. If you try to do it with silicurium-based stuff, the patient will be in the recovery for the rest of the day before the muscle function comes back. When you do pancreas, you need serious pain relief as well, and you need to monitor the heart. So the drawbacks, because there's no such thing, as someone said before, as a free lunch as well. But we have a more complex needle placement than if we do something with microwaves or RFA. We need several needles, and they have to be in more or less the correct positions. The anaesthetist needs to be aware. It takes a little bit more time than just putting a microwave needle in, waiting 10 minutes, and then you're done. But one of the presentations this morning, we're talking about whether you should resect the primary tumor if there are unresectable and untreatable liver metastases. And this is just showing one of the problems that we have today, because to my mind at the moment there is no such thing as an untreatable liver metastasis. We can get at them all with IRE. You have to define, if you start doing this, my recommendation is that you define a needle pattern, how you want to place the needles before you actually start. Because when you're standing there with a patient, you really need to know precisely, this is how I plan to do it. Metallic stents, if you're treating in the head of the pancreas, are a little bit of a touchy subject. People have not been able to show that it's a problem treating around metallic stents, but most people will not do it. First of all, it's the only contraindication that's been mentioned by the company that makes the machine. And we have had some cases where it seems very likely that current has been conducted by the metallic filaments of the stent and induced heat. So most people at the moment will treat up to a stent, but not across it. So a couple of examples. You've got this patient with a large tumor in the head of the pancreas, growing around the superior mesenteric vein. And this is the day after. And you'll see you have a round area here with no contrast enhancement whatsoever. So we've taken out a 5 centimeter large area in the head of the pancreas. And the patient, morning after, the patient came walking down to radiology because there are very, very few side effects. They might develop a mild pancreatitis that will dissolve in 2 to 3 days. After 1 month, it looks like this. After 3 months, it looks like this. She eventually had peritoneal spread, but she actually lived for almost 3 years with that tumor from discovery. And just briefly mentioning how you place the needles. We heard Professor Schmidt this morning saying that he preferred a CT guidance. I do most of my patients under ultrasound guidance, and there are ways around. If you want to place it under ultrasound guidance, CT guidance, or intraoperatively or laparoscopically, it's not a big difference. There are ways of working around the problem of not knowing the exact distance between the needles. It's just how you work the machine, because there's always going to be one parameter, which is tissue conductivity, that you don't know anyway. So that's why we give 10 pulses, look at how many amperes we end up with, and then go on with the treatment. We've just gone through our first 45 treatments in the head of the pancreas, and trying to assess the complication rate, because if we do this, we need to keep the complications down. So this is 45 IRE treatments, all obviously with biopsy-verified tumors. And we had complications in 15, which seems quite a lot, because it's a third of the patients. But we did it under the Dindot-Clavian scale, because most of the complications will be surgical complications. And I hope the surgeons here agree with me, but my surgeons at home tell me that the great divider is between 3A and 3B, because a 3B complication will require general anesthesia, whereas a 3A complication can be dealt with in other ways. And if you look at it that way, we only had 3 serious complications. Most of the others were dealt with interventional radiology or just pain relief. I'll just show you the next ones. Small infections, pain relief, etc. But it's a study, so they have to be recorded as complications. But furthermore, the patient that died, the fifth degree here, that was actually not from the treatment, but he had an edema. He didn't have a biliary stent in. He had the treatment. He had an edema in the area that caused the jaundice. So he was going to have an ERCP and endoscopic stenting, and he died during that anesthesia from respiratory failure. So it wasn't, again, it's a study, so it has to go in, but it wasn't the actual IRE treatment that caused it. Another patient where you have got a fusion image of that's a CT and an ultrasound. These are both pre-ablation. So you have the tumor up there. And the next fusion image is post-ablation, where you have the tumor here, and you have the ablated area, non-contrast enhancing, and you can see the ablation area going down around the superior mesenteric vein and down to the superior mesenteric artery without causing any damage to the blood vessels. Another patient, this is the next one is probably the nicest ultrasound image I've taken, because we placed needles all around this tumor, and the day after it looks like this, where you can see the ablated area here. You've got the celiac trunk of the SMA, and we've ablated all around, and there's even this little side branch to the liver from the SMA is intact. And we had no complications at all from that treatment. Another important point, I think, when we go through complications, if we treat in around the pancreas, is that if you disregard the fact that we're, as we said before, we're not trying to cure, we're trying to improve, prolong life. But we are actually ablating around arteries, veins, stomach, duodenum, colon, small bowel, bile duct, pancreatic duct. You've got quite a lot of nerves around there. And if we can do that with fairly limited complication rate, we can also treat other areas and use that as a rationale for doing it. This is a patient that had nephrectomy, right nephrectomy, and he's got a metastasis up here in the right adrenal. And you can actually see next to it, they tried to ablate it with microwaves. We're slightly worried about the colon, which has ended up just below here. And he's had surgery 3 times, so the surgeons refused to open it up again. So we placed 3 needles around that lesion, and the day after it looks like this, where you have no contrast enhancement at all in the metastases, and it looks like this a year later, and he's recurrence-free as far as we know at the moment. We can, of course, do this in the liver as well, and whereas the pancreas is sort of flagship, it's the thing that we can do and no one else can at the moment. There are several things in the liver that probably is slightly more in the long run interesting, because we know from microwave and RFA ablations that if we can remove colorectal metastases and HCCs, we actually do a lot for the survival of the patient. This is a patient with colorectal cancer, and she's had, as you can see, a right hemiapatectomy, but she's also got recurrent disease, one there, and above all, this metastasis here, which is below her only remaining portal vein, so that's not ablatable and nor resectable. And we place needles around that as well. And this is what it looks like the day after, where you have contrast enhancement in the rest of the liver, and you have the ablated areas down here, and you have the portal vein in the middle, and you can see the intact vessels in the ablated area as well. If you compare that, there's a microwave ablation up here. If you compare that, where we've taken out all the blood vessels, to this area, where all the normal blood vessels are still intact. This lady is also recurrence-free. This is one of the first ones we did. This is done in October 2011. Just a few other cases. One metastasis wedged in between the hepatic veins. This guy was playing golf in the Canary Islands when he had his first problems from his cancer, and a year later he was again playing golf there. He had peritoneal spread, and they did HIPEC on the peritoneal spread, and we took out this metastasis. And he's also tumor-free. Just pointing out that it's not something that needs to stand completely alone, because in this patient, we've had the metastasis here that we've treated. On a subsequent CT 3 months later, it looks like you have a local recurrence, and we've done that with microwaves, because with IRE we treated the bit of the tumor that was close to the vessels and couldn't be treated in any other way. The recurrence was far away from the vessels, so it was easy to put a microwave needle in there. Just another liver example where you have this metastasis wedged in between hepatic veins and the only remaining portal vein, and it looks like this on the contrast enhanced ultrasound the day after. You can see the ablation zone in the middle of the veins there, and I very conveniently cropped the pictures. You can't see the size of it, but that ablation is 2.5 by 3 centimeters wedged in between the vessels without complication. But being able to take out a focal lesion is one thing, but we need to know that we're actually doing some good for the patient as well. And results are coming in, and if you sort of bunch things together, you've got Martin in Kentucky and Rajnarayanan in Miami. Professor Martin is a surgeon, so he does it intraoperatively. Rajnarayanan is an interventional radiologist. He'll do it under CT guidance. Monson is my group. We're doing it with ultrasound guidance, and the results are more or less the same. You get both an improvement in progression-free survival and overall survival at the moment between 8 and 9 months. You have to remember that this includes a very, very steep learning curve to begin with, because you can't have serious complications in the first patients, because then you won't be able to do any more. They'll shut you down. In the liver, we have local recurrence that's slightly higher than with RFA and microwaves, but we're still overall at a local recurrence rate of 25%, which means that we're able to take out about 75% of metastases that are not able to be treated in any other way. Just the last one, showing you the tumor wedged in here, and what it looks like afterwards. You see all these large collaterals up there, and we've been able to treat them anyway. And that's just the conclusion, saying we seem to be able to treat around very large vessels and other critical structures without serious complications. We're using it in the liver and pancreas and prostate at the moment, but kidney and lung are coming, other miscellaneous areas, and I think it's very promising for many different tumors. Thank you very much.
Thank you very much, Professor Nelson, for your